Hello everyone. This lecture will be about pericardial diseases. I am Dr. Ahmed Farid. I am MD Cardiology and Fellow of European Association of Cardiovascular Imaging. So we're talking about the pericardium. The pericardium itself serves to provide the lubrication between the heart and the surrounding mediastinal structures. And the pericardium is composed of a fibrous sac that contains the heart and the root of great vessels, and it's composed of mainly of three layers: the inner layer, visceral layer, and the pericardial space, which contains the pericardial fluid, and the outer layer or the parietal pericardium. And these images make this more clear that the visceral pericardium is stuck to the surface of the heart itself. Then there's a space where we have the pericardial fluid, and there an outer, the parietal pericardium around it. So the echocardiography is the first line examination for the diagnosis of suspected pericardial diseases, and the cause of pericardial disease may also be determined by echocardiography at the same time. And moreover, the echocardiography may be very helpful for the follow-up of pericardial diseases and for guiding treatment like pericardiocentesis. So what abnormalities of the pericardium we're going to talk about? We're going to talk about the pericardial syndromes, including the pericardial effusion, the cardiac tamponade, and the constrictive pericarditis. Let's start with the pericardial effusion. The pericardial effusion is defined as abnormal collection fluid in the pericardial sac between the visceral and the parietal layers of the pericardium, and it may be clear, infective, or malignant, and may contain fibrinous strands, blood, like in hemopericardium, and like in after trauma or in cardiac surgery. And these short movies give you an idea how it looks like to have a pericardial effusion around the heart. You have two layers, the parietal pericardium and the visceral pericardium, and there is a space in between that contains the pericardial fluid, and we know there is big separation here between these both layers, which meaning there is abnormal collection of fluid in this space, which is the definition of the pericardial effusion. But be note there's some normal findings so as not to be mistaken as pericardial effusion. You may have a small amount of fluid, like a small echo free space in the posterior in the AV groove, increasing in size in systole and may totally collapse in diastole. So this is a normal finding, or this is the normal amount of pericardial fluid. So you should not mistake this as pericardial effusion. So how could you quantify the pericardial effusion? So if you have the space or the equal free space at any distance is less than 1 centimeter or 10 millimeters, this is a small effusion. So this is less than 100 millimeter. If you have the separation is 1 to 2 centimeters, it's about the moderate amount of effusion. And if you have more than 2 centimeters, it means you have large pericardial effusion, which is equivalent to more than 500 milliliter of fluid. And this image is explaining this in more details. You have here a trivial, which is less than 1 millimeter, the small, which is around 1 millimeter, the moderate 1 to 2 centimeters around the heart, and the large, it's more than 2 centimeters around the heart. And this is also show another example of a small effusion from the parasternal shoulder axis view, and another example of the moderate to large pericardial effusion in parasternal and short axis view. So you can see here that you need to visualize the effusion from multiple windows to know the amount of fluid where it is more collected toward, and if it's collected in a wall rather than another wall. So it's not maybe equal in all the sides around the heart. And when the effusion is free flowing, the gravity dependence may lead to changing in the distribution according to the patient position. Like if a patient is a little bit sitting, you may see it in the inferior, around the inferior wall. So this is important to know that if it's free flowing, the gravity has an effect here. One of the most important differential diagnoses for the pericardial effusion is to differentiate it from the pleural effusions. So this is a big conflict, but we will try here to put some points to differentiate the pericardial from the pleural effusion. So you should best assess from the parasternal long axis with a big depth, so depth from 20 to 28 centimeters, so as to see the whole heart and part of the pleural. The pleural effusion, the pericardial effusion is anterior to the descending aorta. Like you can see here, this is a descending aorta. And if it is anterior to the descending aorta, this is a pericardial effusion. And if it is posterior to the descending aorta, it is a pleural effusion. Also, another way for the differentiation is the effusion usually is the pleural effusion is usually behind the left atrium, is more likely to be pleural than a pericardial effusion. Another differential diagnosis from the pericardial effusion is the epicardial fat. As you can see here, it's usually in the anterior part of the heart without any pathological significance, and one of the most important differentiation of the epicardial fat from the pericardial effusion is that the pericardial fat has higher density. It appears at white echoes with ultrasound compared to the fluid that appears like dark, clear fluid in this area, which is in the pericardial effusion. So, what you are looking for by echocardiography to assess a pericardial effusion. So, if you do an echocardiography to assess a pericardial effusion, you look number one for the presence, if there is a pericardial effusion or not. As we had said before, that the presence or the pericardial effusion appears an echo-free space external to the myocardial wall, increasing size in systole, and its absence doesn't exclude the diagnosis of pericarditis. So as we're looking here, this amount around the heart is a pericardial effusion. So now we confirm that it is present. The second thing is to define its location. Is it localized or circumferential around the whole heart? And 3D echocardiography may be helpful in this situation, or may be helpful to look in loculated effusion to define the borders of loculation around this area. The third thing is that to try to define the content of the effusion itself. So it can present with adherences, or may contain fibrinous material, or may contain clear fluid, or may contain blood, appears as hematoma, which shows similar density, similar to that of the myocardium, like the images here noted by the arrow. Another important thing when the echocardiographic assessment of pericardial effusion is to determine the amount. As we had seen before, you could determine the amount about the distance between the two layers of the pericardium. Less than 1 centimeter, 1 to 2 centimeter, and more than 2 centimeter is large effusion. But it's less important compared to the rate of accumulation, as the rate of accumulation has more hemodynamic impact rather than the amount itself. A very important thing, and the echocardiography shows superiority in this, is the hemodynamic consequences of this effusion. So using all the echo modalities, the assessment of potential tamponade or constriction physiology, as we will see this in details later on. You're also looking for associated lesions, like if you see some masses, you see tumors, you see aortic dissection, rupture of ventricular wall, signs of myocarditis, and more may give you an idea about the cause of the effusion you are seeing. Now let's move on to the cardiac tamponade. And the cardiac tamponade is defined as life-threatening clinical condition related to elevated intrapericardial pressure above the normal filling pressure of the heart. So here the amount of the pressure inside the pericardium is exceeding the pressure inside the cardiac chambers itself, so it causing then to compress and to tamponade. Also, the definition of cardiac tamponade, including the presence of pulsus paradoxus more than 10 millimeters decrease in systolic blood pressure with inspiration. So, in cardiac tamponade, the rapid accumulation of fluid or large effusion makes the intrapericardial pressure more the intracardiac pressure and causing them to collapse. Let's see from this movie here. This is an example of RV diastolic collapse, RV free wall diastolic collapse from the parasternal long axis view, and here how it looks from the parasternal short axis view. And here you can see this, the RA is collapsed from the apical four chamber view, and here from the subcostal view you can see clearly the RV collapse. Normally, there is some variability of the flow across the mitral and the tricuspid valve with inspiration and with expiration, but it's usually never exceeding 30% in this variability, and we can detect this by using the pulsed wave velocity. Here in either the cardiac tamponade or in pericardial constriction, these values are exaggerated more, and it's more related to the variability between the inspiration and the expiration, as we will see later. So, in pericardial effusion, you have an increase in the intrapericardial pressure. So, this increase in intrapericardial pressure may lead to right atrial collapse, which is not specific, but it may lead to right ventricular diastolic collapse, which is very specific if you see it by the echocardiography, especially in the 2D. And also the pericardial effusion may lead to impaired ventricular filling and increased interventricular dependence. So this is causing the reducing in the left ventricular filling during inspiration and increase in RV filling during inspiration. So you have one of two scenarios. If you have an acute pericardial effusion, this causes rapid increase in the pericardial pressure, and this lead to tamponade even with a small amount of effusion. But in cases of chronic effusion, there is a slow and indolent process, the pericardium remodel and permit large amounts of effusion without significant hemodynamic effects. As we had seen in a lot of patients, you have large pericardial effusion, but it doesn't cause tamponading. So, as we had seen before, that the rate of accumulation has more hemodynamic impact rather than the amount itself. So how to assess the cardiac tamponade by the echocardiography? You need to see all the 2D standard views, all the views, the parasternal long axis, the short axis, the 4-chamber view, the 2-chamber view, the subcostal views. You should look at the heart from all the views available you can get. And it's preferable to use a spirometer if your machine has this ability. This is very important and will give you more accurate assessment of the hemodynamics. So what is the parameters to evaluate? You need to evaluate for the RA collapse during the systole. You need to assess for the RV diastolic collapse, either in the parasternal long, short is usually the best views, or you may see a swinging heart in the 4-chamber view with a free floating in a phasic manner if the amount of fluid is rather big. So this is what you can see here from these images. The white arrow on the left side is pointing at the RA collapse, and the white arrow on the right side is seeing the RV diastolic collapse. Also, you should note or take care to the compression of the LA and left ventricle, and the reciprocal changes in the ventricular volume and septal motion toward the left ventricle with inspiration or toward the RV during the expiration. And this could be easily more assessed by the EMA mode. The EMA mode is of critical importance here. You can use it to assess the cyclic variation of the effusion size, the respiratory changes of the inferior vena cava, the timing of the wall compression, and the abnormal ventricular septal motion. As you can see here, and if this patient has a cardiac tamponade, you can see that the IVC are dilated and non-compressible and not collapsing with respiration. If you're going to use the pulsed wave Doppler, you want to record at the tip of the mitral and the tricuspid valve, and you could record it at the hepatic vein, and you adjust your sweep speed at 25 millimeter per second to see the respiratory variation, and preferably if you have a respirometer over this curve, it will give you more accurate assessment of the hemodynamics. So what's the parameter here to evaluate? You see the mitral and tricuspid Doppler velocity profiles with respiration variability exceeding 30% in the mitral and more than 40% in the tricuspid. And this is a more clear image of this. You can hear with the respirometer overlying the ECG and the pulsed wave Doppler at a very fast speed, 25 millimeter per second. You put a point over the E wave of each complex, and then you measure the difference in inspiration and in expiration. The color Doppler here, it may help you to identify if there is wall rupture in case of a complication of the myocardial infarction, or you may detect AR in cases of aortic dissection if the effusion is a secondary complication to aortic dissection. Also, one of the big benefits of the echocardiography is using the echocardiography guided pericardiocentesis. It has a big role in the pre-assessment for determining the distribution, the depth of effusion, the optimal puncture site, and the guide direction of the needle. During the procedure itself, it helps in the confirmation of the pericardial axis, visualization of the tip of the needle, and eventually the microbubble injection to confirm that you are in the pericardial space, not inside one of the cardiac chambers, and to decrease of the pericardial volume with suction of the amount of pericardial fusion. And post, it assesses for the completeness of fluid removal and hemodynamic consequences with disappearance of the signs of pericardial tamponade. And this is examples of images pre with a big amount of effusion, and this is a post with just a small rim of effusion around the heart. Now let's move on to a very important topic, is the constrictive pericarditis. And the constrictive pericarditis is a fibrous thickening and stiffening of the pericardium around the heart, and the layers of the pericardium thicken and adhere together, eliminating the pericardial space, and eventually the heart became stiff and restricted diastolic filling, result in reduced in cardiac output. And the impaired cardiac diastolic function due to thickened and inflamed and adherent frequently calcified pericardium is the main pathology here. So what is the causes of constrictive pericarditis? It's usually result from a chronic pericarditis and the fibrosis caused by infection, neoplasms, or uremia. It may be also caused by tuberculosis, viruses, or trauma, or prior radiation therapy, or it may be just idiopathic. The hallmark for the diagnosis of the constrictive pericarditis is the presence of septal bounce, or checking, or shudder. What happens to cause this septal bounce? It's abrupt cessation in the diastolic filling within the non-compliant pericardium due to noticeable pattern of checks or bounces of the interventricular septum, and this is a reflection on the ventricular interdependence. As you can see from this movie here, there is a shudder of the septum from the right ventricle toward the left ventricle with inspiration. So this is the true definition of septal bounce. So the role of echocardiography here and the use of multiple echo modalities is crucial for the diagnosis of constrictive pericarditis. Using the 2D may show thickened and calcified pericardium, and if calcific, any acoustic shadowing is seen, and there's possible abnormal septal motion and septal bounce, which is usually diagnosed by 2D or by M mode. The use of M mode, it helps you for the definition of the thickness of the pericardium and detecting the respiratory changes of the inferior vena cava, is it compressible or not, dilated or not, and also to detect the abnormal ventricular septal motion. As you can see from the image here, you can see that the posterior wall is rather flat, but the interventricular septum is moving up and down with respiration. So this is a classic septal bounce by the M mode. And the thickening of the pericardium, it's usually 3 to 5 millimeters, but this is not sensitive, and this is in the absence of thickening doesn't exclude constrictive pericarditis. The use of pulsed wave Doppler for the diagnosis of constrictive pericarditis is crucial, as you need to put your pulsed wave Doppler at the tip of the mitral and tricuspid leaflets and at the hepatic veins, and also adjust the sweep speed to 25 as we used with the cardiac tamponade for detecting of respiratory variations, and also the tissue Doppler help to assess the mitral and tricuspid annulus velocities. As you can see here, putting the pulsed wave velocity Doppler on the mitral and the tricuspid, you can see there is marked variability between the inspiration and the expiration. You see it with the inspiration, the tricuspid valve velocity increases, and with expiration it decreases. But the opposite occurs with the mitral valve, where it was inspiration it decreases and it increases with expiration more than the previously mentioned 30% for the mitral and 40% for the tricuspid valve. So the mitral Doppler velocity with inspiratory decrease more than 25%, the tricuspid Doppler velocity with inspiratory increases more than 40%, dilatation of the IVC and blunting of respiratory changes, and increase in flow reversal during expiration in the hepatic veins. The use of tissue Doppler here, you can see that the septal E prime is more than 7 cm per second, and the lateral is usually less than the septal, which is defined as the annulus reversus, which is a very important sign and specific sign for constrictive pericarditis. Also, the strain is usually normal of the left ventricle. But there are some pitfalls in the diagnosis of constrictive pericarditis, as the absence of the thickening or calcification doesn't exclude the diagnosis. So if you have a normal thickness of the pericardium, this does not exclude that you may have a pericardial constriction. The mitral inflow respiratory variation can also be present in acute heart dilatation, pulmonary embolism, RV infarction, pleural effusion, and COPD. So you should be aware about the clinical situation of the patient and put all your data in the context of the clinical presentation of the patient. The respiratory variation of the mitral inflow can be absent or revealed by the head up tilt test. And this is an example of how a thickened pericardium could be seen, but actually in the echocardiography, especially the transthoracic, is very insensitive for the detection of the pericardial thickening. So moving on to the Doppler findings of the constriction over the mitral inflow, you may have an exaggerated E/A ratio, short decel time, exaggerated respiratory variation in E velocity more than 25%, as we seen before, and seen more reliably when patients are well hydrated, not in dehydrated patients. Also, the hepatic veins may show expiratory increase in diastolic flow reversal. And the hepatic flow reversal is usually secondary to elevation in the right atrial pressure. The hepatic vein Doppler reveals the pressure tracing significant on a prominent A wave and a prominent Y descent, as you can see from the images here. The image here is a collection of the findings of the patient with constrictive pericarditis. You may have the M mode with the classic septal shuddering or septal bounce detected from the M mode in inspiration and in expiration. This is the Doppler across the tricuspid valve. This is the Doppler across the mitral valve with the variability of respiration, and this is the tissue Doppler of the mitral annulus. And this is the IVC. As you can see here, it is dilated and non-compressible with no respiratory variability. And classically, there is a pericardial thickening and a calcification in constrictive pericarditis, which may not be seen by the echocardiography but detected in other modalities like the CT or MRI. But up to 20% of the patient with constrictive pericarditis, confirmed constrictive pericarditis, show normal pericardial thickness even in CT and MRI. And the pericardiotomy is equally successful in those with and without increased pericardial thickness. That's why the hemodynamic assessment of patient with constrictive pericarditis to diagnose the case is of crucial importance. And because many of these patients were presented to the echocardiography with the diagnosis of heart failure and volume overload, it's important not to only evaluate the LV systolic function, but to be aware of the echocardiographic findings of constrictive pericarditis. As I am always saying, eyes don't see what minds don't see. You should always keep in mind and search for the signs of constrictive pericarditis to see it in the patient. The most important differential diagnosis for the constrictive pericarditis is to differentiate it from restrictive cardiomyopathy. And and here I will put some table to compare and to try to get the best how to differentiate constrictive pericarditis and restrictive cardiomyopathy. You're starting by the history. In the restrictive cardiomyopathy, you have a history of infiltrative disease. You may have the exposure to radiation or cardiac surgery. And in constrictive pericarditis, you may have history of recurrent pericarditis, you may have history of chest trauma, you have the cardiac surgery before, and you may have prior exposure to radiation and prior surgery. And the respiratory effect in the restrictive pericarditis, in restrictive cardiomyopathy, there is no septal bulging, but in constrictive pericarditis, there's a classic septal bounce you can see. Also, the right atrial pressure is elevated in both the constrictive and restrictive cardiomyopathy, and the pulmonary systolic pressure in the constrictive pericarditis is usually mildly elevated, but in restrictive cardiomyopathy it's moderately to severely elevated because the main problem here is in the diastolic function. And by the 2D echocardiography in constrictive pericarditis, you may note that this pericardial thickening or no effusion. But in restrictive cardiomyopathy, you may have left ventricular hypertrophy and usually with normal left ventricular systolic function. And here comes the most important differentiation between the constriction and restriction is the Doppler assessment. So you have for the mitral flow, you have a respiratory change in the E prime more than 25%. In restriction, you don't have respiratory variability in E velocity, and the decel time is short in both the constriction and the restriction, but the E over A ratio is more than 2 in restriction. For the tricuspid inflow, you have a respiratory variability of the E velocity more than 40%, and in the restriction it's within the normal, so it's less than 15%. And you may have the hepatic vein flow, it's decrease in diastolic in constriction, and systolic is usually less than the diastolic flow in the restriction. And the pulmonary vein flow, you may have respiratory variability more than 25%, but in restriction there is no respiratory variability. The mitral annulus velocity in the constrictive pericarditis is usually more than 8 cm per second, but in restriction it's usually less than 8 cm per second. And you may note in the constrictive pericarditis the annulus inversus that we had said before. In constrictive pericarditis, you may have some specific forms like the transient constrictive pericarditis, effusive constrictive pericarditis, and the chronic constrictive pericarditis. In transient constrictive pericarditis, that there's a temporary form of constriction usually occur in pericarditis due to the inflammation of the pericardium in the acute pericarditis, and it's usually have some mild effusion and resolve with anti-inflammatory therapy within several weeks. That's why in patients with newly diagnosed constrictive pericarditis who are hemodynamically stable may be given a trial of conservative treatment for 2 to 3 months before recommending pericardiotomy. So if you diagnosed your patient with constrictive pericarditis, it may be the first entity of the transient constrictive pericarditis. So you should give him a treatment of anti-inflammatory and follow him up for up to 2 to 3 months provided he is hemodynamically stable before sending him or taking the decision to sending him for surgery. The effusive constrictive pericarditis, where it's classically the constrictive pericarditis is dry, but in effusive constrictive pericarditis you may have some amount of fluid of pericardial effusion between the layers of the pericardium. So the action here is dual, the constriction from the pericardium itself and from the pressure of the amount of the pericardial fluid that in the pericardial space. And the effusive constrictive pericarditis in most cases in developed countries are idiopathic. However, tuberculosis is the most common cause in developing countries. Another rare entity of the pericardial diseases is the pericardial cyst, which is a benign lesion consisting of a delineated insulated pericardial portion. And by the echocardiography, it appears a thin-walled structure located near the heart, more to the right and through a cardiophrenic angle, and it's usually echo-free with no color Doppler flow across it. The main problem here is the differential diagnosis of the pericardial cyst. It should be differentiated from malignant tumor or extrinsic mediastinal compression. The pericardial cysts are typically congenital but may be infectious in etiology and mostly of little clinical significance unless there is associated with symptomatic compression of the cardiac structure. Also, another entity of the pericardial diseases is the congenital absence of the pericardium, which is usually a rare condition and occur in isolation or in association with other congenital heart diseases. And the clinical presentation is non-specific and include chest pain and dyspnea, with the clinical examination significant only for laterally displaced apical impulse. So it may be classified into either a total absence of the whole pericardium, which is not common, and the partial absence, which is less common. So you may have the partial left side or the partial right side absence of the pericardium. And the characteristic for echocardiography in this patient is a teardrop heart, where the heart is elongated and the atria is elongated with widening of the ventricle, so the heart appears like a teardrop. So the main hallmark findings, echocardiographic findings in the congenital absence of pericardium is the displacement with extreme lever rotation or shift to the left of the chest, and the actually getting the images or the imaging of a heart in patients with congenital absent pericardium is very difficult because of the extreme displacement of the heart itself, the exaggeration in the cardiac motion, and the abnormal septal motion. And the partial absence may lead to herniation or strangulation at a portion of the heart. And this is how it looks like. If you can see like a small herniation at near the apex of the right ventricle. So diagnosis should be considered when there is unusual echocardiographic windows. Image acquisition can be challenging because of lateral displacement of the apical views and elongation and enlargement of the cardiac chambers and excessive motion of the heart with abnormal septal motion. And finally, my take-home messages is that echocardiography is the first tool to assess the pericardial abnormalities. Echocardiography is not only beneficial in the diagnosis but also intervention like the pericardiocentesis. Proper awareness of the signs of cardiac tamponade and pericardial constriction is critical in decision making, and thank you.